Good evening, everyone. As we meet today, just a day after Christmas, I would like to wish warm Christmas and season's greetings to all. And it's a pleasure to have all of you today here. Our expert panel consists of Dr. Aparna Erode, who is from CMC Vellore. She's a radiologist expert. We will have Murli Mohan sir, Prabhu Desai sir, Rajan sir, and most probably even Athol Wells, Professor Athol Wells also might join. We have
He has
Dr.
joined.
Yeah, we have Dr. Sandeep Surendran as a rheumatologist today. Welcome, Dr. Sandeep, and thank you so much for coming on such a short notice. And we have one case which needs pathology inputs, and Dr. Ritu will be our pathologist expert. We have six cases, so we will keep our discussion to the point and um, relevant as much as possible. Without further ado, I will just start sharing my screen. First case will be presented by Rajan sir, and I'll just share my screen. Yeah.
Thanks. Thanks, Smita. So this is a 73-year-old male and never smoker, tobacco chewer, diabetic since about 11 years, carpenter. And he complained when he saw me first 3 years ago of grade 1 MMRC dyspnea, non-progressive for 8 months. He'd lost about 10 kilos then. He was 77. He was 87 18 months back. And his CT, he was diagnosed ILD, no rheumatological symptoms, CCP negative. ANA was 1 in 100, and a blot showed a few mild positivities that time. Uh, we put him that time because it was diagnosed as probable UIP on nintedanib. But he was intolerant within a couple of months itself in December 2022 when he was moved to pirfenidone, gradually up the dose to 1800 mg a day. Until about the middle of this year, he'd been well. He was dropping appetite on pirfenidone over the last 3 years, living in Pune and managing his wholesale shop. His weight was around 81 kilos. The turn of events actually happened in the middle of this year in August when um, he met me because he was anxious because his wife died of MDA5 antibody, rapidly progressive ILD, in June 25. So he lost another 5 kilos after that. More fatigued. He was commenced on mirtazapine, which has been stopped since a month. We did a repeat ANA, 1 in 200, fine speckled. The blot showed weakly positive autoantibodies. Rheumatology review, and Varsha's on this call, was negative. Uh, and then in December 2025, now when I last met him a few weeks ago, he's feeling better. He has dyspnea only on climbing stairs. The family history, the younger sister had RA-ILD, expired at the age of 62. And as I said, his wife died of MDA5 positive ILD. And this is his current blood workup. But you can see nothing really earth-shaking there except for that CEA, which was 10.6, which we were thinking of repeating. He had no GI symptoms or anything, and he wasn't grossly anemic either. 13.4 is pretty decent. Next slide. And so his drugs were really in the early 2022, nintedanib for a couple of months, diarrhea, couldn't tolerate. Pirfenidone, 600 3 times a day till date, and mirtazapine for a couple of months after his wife expired and then stopped since a month. Next slide. And then maybe Aparna could show us the CT. Here's the lung functions. Yeah, before Aparna gets the CTs out. Reasonably stable, but he's dropped in the last 6 months. That's his DLCO and his walk tests. His pulmonary artery pressures are 50. So and this was his ANA profile negative, ANA blot negative. Then we did a myositis profile, which showed up a lot of these antibodies, which I wanted Varsha's and Mithun's input on. And then we repeated a myositis profile because the MDA5 wasn't on this blot. And this is what came in the sense the MDA5 was negative. But I think this tells you probably that these weekly positive antibodies done 6 weeks apart can vary so much. If you can go to the last slide, so you see uh, sort of a 1 plus bordering on 2 plus here. Then you go to a 1 plus again the next 6 weeks later. So I had certain questions on this gentleman. Next slide. So our provisional diagnosis was IPF with a probable UIP 2022, considering his age, probable UIP. Sister died of RA-ILD, wife died depressed. Now, based on the scans, let's see the scans and then I'll put up the questions. Yeah, Aparna.
City, which is 11th of September 2025. So here we see there is some
Can't hear you,
reticulation.
Aparna.
Oh,
Can you hear her, Asmita?
We can hear it is feeble. If you will speak louder, we can hear
yeah.
Aparna.
Is it
Yeah,
better now? Is it
yeah,
better?
much
Yeah,
better.
better,
Okay.
better.
Sorry. Yeah. So we have one CT which is from September 2025, and it's partly like an expiratory CT. We don't have a full proper inspiratory CT. So on this CT, we are seeing reticulations, which are having some subpleural predominance in the upper lobes. Few areas of mild traction bronchiectasis, some areas of minimal like focal kind of honeycombing is there, but not honeycombing is not a main pattern that we are seeing. In the lower lobes and subpleurally, we are seeing more reticulations. Little bit ground glass is there, which I'm presuming is partly because of the it being an expiratory CT. So this is so it's subpleural and basal predominant reticulations and traction bronchiectasis, not much of honeycombing. So the pattern wise, we would like to say like either like a fibrotic NSIP or probable UIP like pattern. Lymph nodes, not really much significant nodes, 8, 9 millimeter size nodes. Main pulmonary artery is just borderline, it's 29 millimeters, not fully dilated. A lot of coronary artery calcifications are there. But I saw that you've said echo wise the LVEF is normal. So those are the findings on the CT. I saw that there was some report where it has remained stable from some previous CT from 2022. I don't have that, but I saw one report saying it was stable.
Oh, they didn't put in the 22 films?
No, that is not there.
Oh, that's surprising. Because Bhavin has reported on those scans, and that
Yeah,
was a probable UIP pattern that time.
yes. And he has said it's stable from 22 to now.
Right. I
Do
think
you, mi-
mildly progressed,
My
Aparna.
progression, I think. That's what Bhavin wrote.
Yeah, I think he had
Okay.
written mild progression.
Okay. I just saw that one, some report saying it was stable, but I don't have the previous, yeah.
Would you mind going to the upper lobes?
Yes, sure.
I'm probably overinterpreting it, but I'll show you what I was asking. I just get a sense of interlobular septal thickening in places which I don't normally see on a scan.
Yes, I also thought of it, and I thought because of the coronary artery calcifications, whether there was some edema thing, but I think
Well,
LVEF is normal. Yeah.
yeah, I wasn't necessarily thinking of heart failure, and I wasn't sure what it meant, except that you can see interlobular
Yes.
septal
Yes.
thickening
Yes.
sometimes in sarcoidosis, but usually more in the lower zones. And then it just seemed to me a feature that was slightly out of sync. I wasn't sure what to make of it. And it has been said that the art of being wise is the art of knowing what to overlook. But it seems to me that this is running through the interstitium as you go down in a rather curious way. Sujit, was this feature present? It's a bit less prominent, isn't it, as you go into the lower zones?
Right.
But there
So,
do need to be variations in density in places. And again, I don't want to overinterpret them. Sometimes an element of organizing pneumonia resulting in some perilobular change, but I wouldn't have gone for the upper lobes for that. You could talk yourself into a bit of perilobular change mixed in. And the relevance of that would be it's not something you'd expect to see in IPF, that's all. But I don't think you can look at it and say that it's CTD-ILD just based on that. But it raises the question whether there has been an element of organizing pneumonia at some stage with this perilobular residue in places. But it's subtle anyway. Enough from me.
Would you think of sarcoid based on that? Because yeah,
I wouldn't because of the distribution of it. I don't really understand it. It just strikes me as an odd feature.
right,
So I don't think I would, except to say sometimes sarcoid can
right,
have a UIP or NSIP pattern as part of it, and that is about the only thing. Then I look at the progression and see how stable it's been, which doesn't mean it can't be IP if it has now progressed recently. But I guess it makes you a bit more aware of differentials. So
right,
I'm just if slightly uneasy about the scan. I'd probably be diagnosing IPF, but as a working diagnosis rather than a definite one. And then you start to worry about what you're going to say about autoantibodies and family history, don't you?
right,
So it's just a question mark, that's all.
right. No, I think that's also something that had been, I mean, he got very anxious when his wife died of MDA5 disease, and we had to convince him that it's not infectious. So because I think he just got worried, and because his sister had RAILD, the anxiety was more. And I'm just wondering whether we could be dealing with something besides IPF here. We haven't, and so the question really was whether we should give him consider immunomodulation at all here, because he is an elderly person. Can you put the questions up, Asmita, that I had there?
Yeah.
And because for the first time he has dropped his vital capacity, though it's still above 70% predicted, should we consider going back to nintedanib or just stick with pirfenidone? And what would be the role for immunomodulation? Uh, because he's now lost some weight, so he's getting a little worried with that. But as I said, it's not that bad.
Sujit, you had an ESR of 82, and unless you're using different units, and you
Yes.
made an ESR of 82 would be definitely not something you would expect in IPF, but I
Right.
might have misread it.
Uh,
There's just there are little clues here, aren't there? And then you add them together.
yeah, yeah, yeah.
ESR 82,
Correct.
which is unexplained. Then, like you, I don't trust all these low titer autoantibodies, and so
Right.
a rheumatologist doesn't have to upbraid me for taking notice of them, but I am interested in the family history of rheumatoid,
Yeah.
which I think is going to change likelihoods somewhat. Now that's
Varsha? Yeah. Varsha, what did you feel? Nothing active rheumatologically, right?
Nothing active rheumatologically, Sujit, but I feel I mean, see, he's one of those patients who says, I'm nothing wrong with me. I'm absolutely fine. I'm absolutely fine. But definitely this thing has gone down, what you can say is like he gets breathless on climbing 2 floors, or he gets breathless on walking. What used to earlier walk very easily, he does get dyspneic on. So his activities have reduced.
His activities have come down. That's what I
So his
also felt. Yeah. Yeah. And
See, there are multiple antibodies positive. I mean, in the first myositis profile, the second, there's some difference. But borderline positive, 2, 3 antibodies in the first myositis screen, and this also.
yeah.
MDA5 was negative, na?
MDA5, yeah. So we got that 6 because it wasn't there on that first panel. And this time it's come negative. So that's reassured him on that front. But I'm just wondering, would we give immunomodulation here at all? Because I
yeah.
I'm just would Prahlad?
I think considering his 2022 and 2025 scan being stable, and here in this scan there is no honeycombing, and this is a non-smoker. IPF is very unlikely. I feel this we are dealing with some CTD ILD. Probably he may evolve later on. In 3 years, there is not much progression. There is no honeycomb changes. So I feel we should treat him like an CTD ILD only.
Even I was thinking, sir, before it goes into that stage, we can help him now.
With Dr. Wells has pointed out ESR 82. I think that's a
Oh, yeah.
indicator.
So the ESR 82 and the CEA is high. We'll get it in.
There's four features, Suji. I
Yeah.
still don't understand that CT look, which we've kind of discounted, that
Right.
into the septal thickening. And then if you do look hard, just here and there some perilobular change more peripherally in the lower zones. Not much, but it's
Right.
there. That's the
Right.
first thing. The family history of rheumatoid is the second thing.
Right.
As you've said, the stability for the length of time that there is, admittedly not on immunosuppression, doesn't mean it can't be IPF, but it does mean that the likelihood has to drop. Non-smoker, yes, but of an age. So I would have said this. I think you're entitled to cover a major differential. And you can debate, is IPF still more likely than not? Or is it that it's still there, but it's more likely to be CTD-ILD? I don't think we're very good at telling the difference between 30 to 50% likely and 50 to 70% likely. So I think it's reasonable to say that you might add in, say, a dose of mycophenolate, staying away from steroid, because you're treating a distinct possibility. I think I would still cautiously vote one of those diagnoses which is slightly more likely than not. Without the things I've mentioned, you'd be up at 95% plus. Maybe it's correct. Maybe those four things drag it below 50%. I don't think that matters. I don't think we would stake our management on being sure either way. But Sujit, you've been weighing it up.
Yeah.
So
I think I will also pursue that high ESR and ask his daughter to get some tests done there as well, repeat his CA and lung studies. Yeah. Yeah. I think, Varsha, then we'll consider that after ruling out any
In this
malignancy, no?
scenario, Sujit and Dr. Does the KL6 will help us to
I have no experience, Prahlad, in clinical practice of KL6, but Asmita, you?
So KL6 usually predicts the chances of ILD when already the ILD is there in background of RA. I'm not sure it correlates with the prognostications and everything, but I don't think it will help us to differentiate between CTD and UIP. What do you say, Professor Wells? Right?
I don't know. In fact, I recently.
study in a large cohort, which what were you going to say, Sujit? You
No,
might
no,
have
I was just reviewing a paper on changing the paradigms of clinical trials in ILD.
Yeah.
And one of the sections was on biomarkers, and KL6 wasn't even mentioned in that. I was a bit surprised because that's what's commercially available, but they didn't mention any data on that. Athol?
Well, that's partly because the Japanese held on to it for so long that
Okay.
it's very difficult for anyone else to be allowed to use it.
Ah,
But our data does seem to indicate prognostic value, but quite a large cohort across Denver, Japanese Center, and the Brompton, KO6 certainly didn't seem to be distinguishing between fibrotic ILD types. So I wouldn't be using it for diagnosis. I think on the issue of detecting ILD, yeah, we saw it strikingly up in truly minimal disease. The objection is that these were patients that were known to have minimal ILD, so it hasn't yet been validated for screening. But not here. I don't think it's going to be helpful. Let alone in a patient who has already displayed a slow progression over some years, where you actually do already have a sense of the pattern of disease behavior. Now, maybe it'll take a turn for the worse. Maybe there is an evolution towards UIP in this case, which hasn't yet declared itself with an obvious change on the scan, but the pathways are there. He's of an age, and maybe we will see more progressive disease. You do sometimes see that, don't you? That's partly why I'm anxious that we don't have to take a stand that it's more than 50 or less than 50% likely that it's IPF. I think our stand correctly is that we're not sure and we need to cover both possibilities.
Just one last question, Athol. I know we are over time, but would you send this patient for a cryobiopsy of the Brompton?
No, the screen blurred for the DLCO. What was the DLCO as a percentage of
The last one, Asmita, was, I think,
70.
he'd been above 50 for
55.
55%.
It's interesting the DLCO hasn't actually changed from 2022, even though the FVC has. So that's curious, isn't it?
Right.
And the age was...
Actually, the FVC has hardly changed. That's all. It's just now that it's dropped. The FVC has just dropped.
No, I saw that.
Yeah.
I saw that. But what I was saying is the DLCO hasn't changed in tandem, which is interesting. It does suggest there could have been a technical issue, possibly with the
Yeah.
So, and the scan is said not to have changed. I don't think I would, because in a sense, if you happen to see some UIP in a patient like this for some years, and you think it might be CTD-ILD, well, this patient is allowed to have CTD-ILD with some UIP. Now, I think if it was at presentation, sure, you're saying probable UIP, you're not sure there is UIP, and at presentation, that's helpful. But it could well be that you have little patches of UIP there that have yet to become the predominant abnormality. And your cryobiopsy, if it's NSIP, you're going to say, yes, we'll treat and cover for CTD-ILD. I'm not sure your management would change if you picked up some UIP.
Got it. Perfect. Thank you.
Yeah, thank you. And moving on to the second case, I hope it is visible, right? Can you see my slides?
Yes.
Yeah. The second case is presented by Dr. Sumit Singhania. Sumit, you can give your brief introduction and please go ahead.
Yeah, hi Asmita, and thank you for letting me present this case. I'm Dr. Sumit Singhania. I'm a pulmonologist at Kokila in Ambani Hospital in Mumbai. So about a month and a half ago, I had this 24-year-old primie, 30-week gestation. She usually lives in a village in Rajasthan, and she's recently moved here in Mumbai. She was born. She was born from a non-consanguineous marriage. She is a non-smoker, and she had some prior history of asthma for nearly 5 years, where she was using a basic ICS-LABA. And she had a prior history of tuberculosis 10 years ago, but unfortunately, we didn't have any details on it. Interestingly, she also had some bilateral sensory neural hearing loss since the age of 8 years. And she had right-sided blindness secondary to optic atrophy since early childhood. Now, these are all in her whatever notes she brought to us. So she started with fever, cough, and shortness of breath for a few days when she was admitted in Rajasthan, and she was treated as exacerbation of asthma. Saturation remained around 88%, and they were supposed to be moved out to a bigger hospital, but she took a discharge and she came to Mumbai. I mean, she was okay with that saturation of 88% to travel all throughout and come to Mumbai. Again, readmitted in another hospital where her hemoglobin was found to be 6.2. They kept treating her with broad spectrum antibiotics. She had some steroids as well. She had oseltamivir, although her flu swab never showed any positive results. And she had blood transfusion. Now, according to the family, this was in another hospital. According to the family, after the first blood transfusion, her shortness of breath worsened and she was transferred to us. And when she came, her sats were 94%, but she was on 100%. She was quite hypoxic, so we had to put her on high flow nasal at 100%, tachypnea 30 per minute. She was tachycardic and she had some wheeze, squeaks, and creps all over. She was hemodynamically stable and quite well in terms of fermentation. A blood investigation, the hemoglobin did come up after the transfusion to 9. Her counts were quite high, 26,000. She was iron deficient. She had a CRP of 76. Obviously, she was pregnant. The D-dimer was there, done in another hospital, which was quite high. Coagulation was normal. Her HIV, HbSAg, and HCV were negative. She had an NT-proBNP of 349 only, and we did an echo here, which was normal LV function. She had mild pulmonary hypertension on the echo. Rest of the liver and kidney functions were okay. And she had a sputum done with us, which was TB gene expert negative. Aerobic culture once showed MRSA. Mycoplasma IgM was negative, and the cultures for the TB have been negative till date. And she had a CT scan. So if you could just show the CT slides, please.
Yeah. So this is a CT done in 22nd of November. So we are seeing this left upper lobe, there are post-TB changes. There is scarring and some calcified nodules, pleural thickening. So that is consistent with the 10-year ago history of TB. The rest of the lungs, we are seeing lot of ground glass densities diffusely. There is some small focal honeycombing in the anterior aspect of right upper lobe, very focally alone. Rest of the lungs, extensive ground glass. Some areas of they are becoming more denser and becoming consolidations also. And when we come to the lower lobes, there are these areas of cystic changes, like large low density areas, which look like cysts or areas of sparing, which are there more in the lower lobes and more in the bases. So this is the main things that we are seeing on the lung window. On the mediastinal window, we are seeing few nodes. Some of them are like hyperdense and some are calcified also. For example, this one is calcified, but there are borderline 8 to 9 millimeter size nodes. Pulmonary artery is dilated. It's 32 millimeters. You said echo also showed mild pulmonary hypertension. There's not much of RARV dilatation. Left heart chambers are also not dilated. Upper abdomen, whatever we are seeing, are looking all right. So the main predominant finding is old TB plus extensive ground glass opacities, which are some are becoming confluent and more dense, and also some of these kind of cystic like changes in the bases. So with all the history, whether it is all some viral with some superadded bacterial infection is one thing, with all the counts raised and the fever and everything. But I would definitely like to see how it has improved after all the antibiotics. So this is 20 to 11, so now it is 4 weeks. I know she's pregnant, but whether we can take at least an X-ray or something just to see whether it is really improving, and whether later, maybe after the delivery or something, we can see whether actually there is anything really background ILD or not. Only another thought that came to my mind was sometimes we do see this adenocarcinomas which have these pseudocystic kind of appearance. I just want to keep it at the back of the mind. But in the situation with all the fever and everything, maybe it's all just infection, but we definitely should make sure that it has resolved.
What do you think about that left lower lobe? Not just the cystic area, just a little bit further down. Yeah, perihilar area, just sorry, a little bit up in the left zone. There are some more cystic areas right in the middle also,
Yeah,
or
there are
along the
here and there.
mediastinal pleura.
Yes, yes. There are many similar kind of areas. So that's why I'm like, we do see sometimes that pseudo sparing or pseudocystic or bubbly lucencies, those kind of appearance. So that all these are also there, small, small cystic areas. Uh, Hopefully it's just normal airways which are spared that are looking like that. but I think we should do at least an X-ray now, maybe now that it's 4 weeks. If she is definitely improved, then it's okay. And then later we can just see if there's actually anything underlying or it's all just one acute infection. But the pulmonary hypertension is there, so whether some background something is there, we don't know now based on the CT.
So what have you treated her with, Sumit, and what is the question, please?
So I'll go back to the slides, Asmita, if you can. So we did do an autoimmune profile because she, as I said, she was tolerating hypoxia so well, and this was not. This is over a period of nearly 3 weeks that this was all happening from her first admission in Rajasthan to coming up to us. Sorry. So it was rather odd for someone to remain so hypoxic, and we didn't. I mean, I don't think MRSA could explain that either. And this MRSA was isolated after 2 hospital admissions already. So we did an autoimmune profile which showed ANA 1 plus speckled. We treated her with methylprednisolone because she was too hypoxic and we didn't have any strong, and she was hemodynamically stable and not running fever. So we chose to treat her with steroids, and eventually the steroids were slowly tapered down. She was discharged on 89% room air. And on the first clinic follow-up, which she came 2 weeks ago, her stats were 91%, heart rate. She was still tachycardic, and we were dropping the steroids down. She was kept on her inhalers for treating her asthma. So we go to the next slide. So my first question was that, do we agree that there is any underlying ILD? And of course, it is difficult because there is a superadded insult, but is there any radiological diagnosis of ILD can be made on this? And what should be done regarding the immunosuppression currently? There are other, she has 5 other siblings and they don't have any other features, but she has some other odd things also in terms of the optic neuro atrophy, in terms of the sensory neural deafness. Is there, and those cystic areas at the bottom of the lungs are slightly unusual for any infection in otherwise immunocompetent person.
Sumit, her scan was after transfusion or before transfusion?
After transfusion. So she was treated elsewhere. She got transfused because the family wasn't ready to get the CT done, and we had to convince them really hard to get the CT because she was so hypoxic. And after a lot of, convincing, that she went for the CT chest.
Why do you think she's got profound iron deficiency anemia?
So iron deficiency anemia in Indian women who are pregnant is not uncommon at all. I mean, if you see most of the Indian women, especially from rural areas where there's no regular antenatal services, their usual hemoglobin may be somewhere about 8 to 10 during the pregnancy.
This one is 6.
Yeah.
And my concern is that normally in other settings, you would be saying this is likely to be pulmonary hemorrhage. Now, are you then going to say, because we see this in pregnancy, it takes pulmonary hemorrhage out of the equation? You don't have to cough blood in these cases, and sometimes when they present with more breathlessness, and this isn't admittedly not in a rural Indian setting, of course, I take your point, but there will be quite profound iron deficiency anemia. So somebody has idiopathic pulmonary hemosiderosis without declaring this with coughing blood. And then in that disorder, you do get weird fibrotic change if it's been around for a while. It's well recognized. So it's an uncommon complication of an uncommon disease, admittedly. But it would be in my mind. And I think it all depends whether you feel you can dismiss the iron deficiency anemia. It's one of those things that blurs your view rather than allows you to dismiss it, I think. and then a very full vasculitis screen, and you'd include anticardiolipin antibodies, lupus anticoagulant. They clot, but they can bleed. And so you'd be doing a range of vasculitic examination. She's too sick to have the BAL, but if she wasn't as sick and you did a BAL, you'd be looking for increasing blood staining, and then very dense blood staining with the distal BAL. You probably can't do that. It's no use doing gas transfer because that effect only lasts 36 hours after a bleed, huge rise in DLCO. And this is not like this. So slightly suspicious that there might be alveolar hemorrhage. And if there is, it would not be out of sync with having some weird fibrotic change.
So we did, I'm sorry, I didn't add it in that in presentation. We did do a vasculitis screen. The urine routine was fine. There was no RBC. We did an ANCA. The ANCA was negative. And we did involve the rheumatologist who didn't feel that there was, either other features of vasculitis, extrapulmonary areas, and a platelet count was stable with all of that. So, of course, we didn't do anti-cardiolipin antibodies, but yeah, I take that point.
Well, I think the other thing is that you're then talking potentially about idiopathic pulmonary hemocirrhosis. So by definition, you will not find the auto antibodies with that diagnosis. It's pretty much exclude vasculitis and autoimmunity in general, and you're left with unexplained pulmonary hemorrhage. And it's tricky because sometimes these patients do declare their vasculitis. The most extreme example was some 25 years later. Somebody who had this disorder for 25 years and then declared their vasculitis at that point. So you kind of have to treat for that, but we're jumping, aren't we? You've probably explained away the iron deficiency anemia, but we're left with unexplained major infiltration going on. I think you could talk yourself into an alveolar filling profile with some of the denser stuff. I'm suspicious it's blood. And that's really all I can take it to.
Yeah.
Thank you.
Trally also can look like this after transfusion.
Sorry?
Trally, transfusion related.
It was only 1 unit of
Yeah,
blood.
it won't cause. Yeah.
How is she now, Sumit? What?
So she came about 10, 12 days ago, and she's symptomatically better. She's on 91% on room air, and she's much happier with 91%. She was happier with 85% also before. There is nothing to suggest any ongoing sepsis. She's independently mobile. So I'm just tapering the steroid down and waiting for her to, once she delivers, then we can probably take this forward further.
How long has she been on the steroid?
Sorry?
How long has she been on the steroid?
2.5 weeks.
So that could actually be a response to steroid. You actually said you didn't feel she had responded, but she's gone from 90% on 100% oxygen to 90% on room air over 2.5 weeks with steroid.
Yes, pretty much.
Might well be seeing a steroid response. I think you might have to investigate her when she's a little better, might you not? And rule out hemorrhage.
Yeah, I have a couple of things to say, Sumit. I believe that I totally agree. Even by looking at CT, my first impression was it looks like alveolar hemorrhage. The second is we don't know what was her baseline. We know that she reported to one outside hospital with a saturation of 88 on room air, and then she landed up in Mumbai. But we don't have any idea what was her baseline and what was her previous CT or previous X-ray or anything. So we are just expecting or imagining that things happen now, while whether she was having clubbing or whether she had previous this kind of problem or not, because idiopathic hemocidrosis in her age will be like a childhood, like congenital kind of thing. And I'm sure that Bal will not able to differentiate between hemorrhage and hemosiderosis, but Bal will definitely tell you about whether it is there or not. And definitely, I would like to look at Bal. So she, in your hospital, you people don't do for pregnant lady bronchoscopy and all?
No, it wasn't like that. So we could have easily done initially also, but initially, obviously, her FiO2 requirement was too high.
No,
And
that
so,
also goes in favor because you were giving 100% HFNC and still her saturation was not improving. That goes in favor of hemorrhage, right?
yeah. So this is, but I would say that things got better over. She was here with us for about 10
After
days.
methylprednisolone pulse?
Yeah. So we didn't pulse her, which is because we didn't have any solid proof to say
Yes.
what we are treating. So we just started with 1 milligram per kg to be,
Okay.
to keep a balance. But we could have offered her a scopy, but there were a lot of other issues going on with this woman. There is a hesitation for doing anything from the family side in terms of any invasive procedure. Rest about, CT scan took us 2 to 3 days to convince them
I
to
understand.
treat.
Yeah.
So that
So,
is why
but
when she got
but won't
better.
you think tapering steroids will be risky if she has responded to steroids?
So I'm going very gradual. She is currently on 40 milligram pred, and maybe it's helping a little bit for the baby as well.
Yeah,
But, so I'm planning to keep her on at least 20
20.
milligram
Yeah,
by the time she delivers.
delivers.
Then once the baby is at least safe and out, then we can try tapering further down, or basically first re-imaging at 6 weeks from the first CT scan and see what comes out as a background.
One question to Sandeep, if you are there, Sandeep. So, if ANCA comes negative, is there any point of sending PR3 MPO, Sandeep? Or we
Uh,
can. Hmm.
Actually, now the current guideline is we prefer anti-PR3 MPO over ANCA by immunofluorescence.
So, that also can be sent, na? Sumit, we can send that.
Yeah, we are actually now in our hospital, when we ask for ANCA, we do all three: ANCA by IF, MPO, PR3.
Okay.
Also, just one doubt: would she benefit from adding some sildenafil if it is safe in pregnancy? I think it is.
It's only mild pH, and that too, she's pregnant, and it is not. I don't think it is bothering her too much. There is no sign of any right heart failure there. So
Yeah, there is hypoxia, no?
Yeah.
I mean, you
So,
are saying
Sandeep, what we had seen is acute hypoxia can cause sudden dilatation of all those changes, which we had seen even like because I repeat CT scan for my patients, and even a severe dilatation like 42 millimeter has reverted. So, I would be cautious in starting pulmonary hypertension treatment at this point of time because most of the times acute hypoxia can cause a mild dilatation and also and
so.
she's pregnant.
If the pH is there now that she's better,
Hmm.
wouldn't that mean it's an autoimmune pH with the background of an autoimmune ILD?
Yeah, but we didn't prove. ANA came 1+. Other than that, nothing came, right?
We don't have any proof of an autoimmune
Yeah,
ILD.
yet.
And so to put the pH as an autoimmune etiology is a little challenging, I feel. Athol, you wanted to say something?
Yes.
Couple of things, having seen a fair few of these patients where there is iron deficiency anemia, and they've been bleeding for a while. They do present apparently with new onset problems. So I wouldn't be too prone to say this hadn't been going on for some time, and especially in somebody who happens to have asthma as well. And she was thought to have asthma locally initially. So if she's had asthma in the background, I don't know how you do tease out the likelihood that she's been dealing with bleeding if this is hemorrhage for quite some time. On the dilatation of the pulmonary artery, there are nice studies. You actually need to have hypoxia probably present for 4 months, 6 months to get that. In your acute, you probably have pre-existing something before you have your acute dyspnea. And I agree, once you say there may have been hemorrhage going on for all we know a year, and there's some hypoxia and people have been saying, it's her asthma, then you're entitled to see a bit of pulmonary artery dilatation and not make it autoimmune. And I don't think these patients generally get pulmonary hypertension, actually. You would think they would because blood vessels are being involved. You might expect it, but I very, very rarely see pulmonary hypertension due to a vasculitis.
Okay.
Even though you think you should, but you don't see to.
Yeah, we don't see. You are right. We don't see in alveolar hemorrhage. So, Murli sir?
Can I ask a stupid question, perhaps? Is the fetal anomaly scan normal? I was just wondering if you could get part of her diagnosis from the baby.
We did a scan, and the baby seems to be absolutely fine. And she's already 30, more than 30-week gestation, so the baby is fine.
5-month scan was done, right? Yeah.
Yeah.
You have looked up rare syndromes with optic atrophy and sensory neural defects, haven't you? You've gone on to Medline and you've plugged in alveolar hemorrhage and looked to see if there are familial disorders with that cluster.
I did do a bit of a literature search and putting all the optic atrophy and sensory neural deafness. There are so many cardiac disorder which are associated with sensory neural deafness, but I couldn't find one with the lung.
Okay.
Rarely you can get it with a mitochondrial disorder. So
Yes,
that's why I was asking about the baby also.
Yeah,
sure. So we have a day of sensory neural hearing loss today, and I will move to my case. And my case will be presented by Dr. Marin, who is working as ILD fellow in my department. Over to you, Marin. I hope you can see my slides. Yep.
Yes, ma'am.
Yeah.
So this is a 55-year-old gentleman. He's from Munnar. He works as an electrician and a known case of type 2 DM, who presented to us with complaints of cough with mucoid expectoration, dyspnea on exertion, and wheeze for 1 month. He also has history of weight loss around 3 to 4 kgs over 1 month and hearing loss since the last 6 months, bilateral. So in his past history, he had like 2 years back, he had fever, night sweats, cough, and weight loss. He was evaluated for it and diagnosed with cryptogenic organizing pneumonia in another hospital. EBUS TBNA was done at that time, which is non-contributory, and he had peripheral eosinophilia of around 21% at that time. He was initiated on prednisolone 30 mg and tapered off over the next 6 months. He has no history of smoking, but exposure to pesticides is there. Vitals were stable. Respiratory auscultation revealed bilateral inspiratory squeaks. His total counts were 8,200 and eosinophil count percentage is 9.7. ANA by IF was positive 2+. Aspergillus specific IgG and IgE were positive as well. Anti-MPO and anti-PR3 were negative. ANA profile was negative. PFT was normal and 6-minute walk test was normal as well. No significant desaturation. We did a BAL for him which showed right upper lobe and bronchus intermedius, mucosal inflammation and rugosities with mild narrowing, and there was also significant narrowing of the left lower lobe.
I think we'll see the CT first. Aparna, if you can share. There were 2 CTs if you have received. One was outside and one was from Amrita.
Oh, sorry. I think I got only one. Sorry. This is from 17th of December. Yeah, I have only one.
Okay, no problem.
So in this CT, what we're seeing is mild.
Can you speak louder? I think people will not able to hear.
Yeah. In this CT, we are just seeing mild diffuse bronchial wall thickening alone, and just one very, very small area of ground glass density in the superior segment of the right lower lobe here, and posterior segment of the right upper lobe. Just one very small area of ground glass. Otherwise, lungs are pretty normal only. Just the diffuse bronchial wall thickening alone is there. Not much of mucus plugging, no bronchiectasis, nothing specific for ABPA also on this scan.
Yeah, so What we expected was as a part of workup when we did bronchoscopy. If you can stop sharing, I will
Yeah,
just show.
sure.
Yeah. So what we expected was normal bronchoscopy. To be honest, I also thought that nothing is there. Our radiologist commented that it can be small airway obstruction or something and nothing significant. But um, we saw localized left lower lobe bronchial mucosal rugosity and inflammation, and that was localized to that particular segment, which made me do biopsy from that segment. Otherwise, I would not have touched. The intention was just to finish the workup, find out whether there is a ball, because he had recurrent eosinophilia. I just wanted to see whether there is eosinophilia in the ball or not. But when I did bronchoscopy, I found this mucosa looks slightly abnormal than other mucosa, even though I can see it in the intermediate bronchus, also those rugosity and all. But the maximum changes were present in left lower lobe bronchial, lower lobe bronchus, and we did biopsy from that just because of that. And then I will just share the slides of biopsy with you. So yeah, Marin, you can go ahead with BAL analysis.
So BAL analysis, cytology showed no atypical cells, few lymphocytes, alveolar macrophages were there, AFB smear, gene expert culture, fungal smear, all were negative.
And I think Ritu madam is there, ma'am, if you want to say something. Yeah.
Yeah, so we have three bits of endobronchial tissue, which we are seeing here in the low power, which is lined by the pseudostratified ciliated columnar epithelium. There is some amount of subepithelium which we can appreciate at this power, but there is no alveolar tissue in this biopsy as of now. So we'll see the next slide. Okay, now here this is the higher power of the same, and it's very interesting. On this right side is the epithelium, and under the epithelium you can see that for a good amount of thickness, it's a glazy pink material here which is there just under the epithelium. This glazy pink material is actually the subepithelial fibrosis. So we are having a epithelium subepithelial fibrosis, and beneath the fibrotic area there are these small capillaries, which are kind of sprouting just at the fibrotic margin, and these are surrounded by blue cells and by these orangeophilic reddish cells which are eosinophils. There is no mucus gland hypertrophy. So we've all read in about the Reed index in an asthmatic airway of the thickness of the mucus gland to the entire wall thickness. So there is no mucus gland here, but the fibrosis, the subepithelial fibrosis, which is explaining the rugosity seen by ma'am on clinical, and the wall thickening seen on radiology. So this subepithelial fibrosis can be appreciated here. The next slide is again a lower power, but I am a little worried on the left side here, where this aggregate of lymphocytes and other eosinophils are there surrounding the perivascular, and I would want to see this under higher power to see if I am dealing with any ill-defined granuloma, because we've got aspergillus showing coming up some in some report. And on the right side, these are these cleft-like areas here. So I was wondering whether there are any Charcot-Leyden crystals or any cholesterol crystals. So I'd like to do a polarizing microscopy on this also. And of course, AFB in our country to rule that out. And there's no alveolar tissue. There's no mucus hypertrophy. There is this distinct subepithelial fibrosis, which we can see on this power also. And next slide. I think this is the last one. Yeah. So with this, I would sign this out as a perivascular lymphocytic and eosinophilic process, and I would keep in mind the eosinophilic granulomatosis with polyangiitis first, and keeping that fibrosis occurring there, also see whether I'm dealing with a Churg-Strauss or some ILD or autoimmune. That would be my pathological
Yeah,
differentials.
so this patient now was 3 months before he developed sudden onset of left side sensory neural hearing loss. I think this was a outside this thing, and they found the left side was far worse than the right side, and they started him on steroids. So by the time he came to me, he actually started improving, but he was worried, and so they wanted a checkup. So if we are seeing a CT scan which is normal, that is after a significant dose, almost like 30 milligram, 20 milligram, 10 milligram kind of for 3 months. And then he came to me when he was already on some 10 milligram of steroids. So if my CT scan is normal, I will take it with pinch of salt. I did not intend to do biopsy. The biopsy was taken because there was significant mucosal irregularity. And Anka and PR3 came negative, and we did this audiogram over here also, which was actually identical. But Marin, over to you.
So we took an ENT consultation in view of SNHL, and they advised us to do an MRI brain, which was normal.
Yeah, they were suspecting CP angle tumor or something to rule out, and that is why it was done. And we did not start him on steroids yet. We were waiting for the biopsy result, and our questions are: so is it ILD or was it ever ILD? I'm sorry that the previous CT scan were not. He received steroids 6 months before, and where the biopsy was taken, the cryobiopsy was taken, which was labeled as organizing pneumonia. I don't have those images, but I had CT scan. Unfortunately, Prana could not load it, and that was labeled as cryobiopsy, labeled as organizing pneumonia. Received 6 months of steroid, significant improvement, and this is second episode. And then, is there evidence of systemic or immune vasculitis process linking pulmonary finding with SNHL? And BAL and biopsy mismatch. I could not find any BAL eosinophilia, but there is a biopsy which is showing eosinophilia. So how to proceed, and should I give him steroids? Should I give him more immunosuppressant?
Is there any other organ involvement?
I think we have ear now. We have ear, we have lungs.
No. In terms of heart, in terms of hepatosplenomegaly,
No, nothing.
in terms of skin,
no skin, no,
or,
nothing else. Whatever we have said, yeah, that's it, nothing else.
Yeah, but you've got a vasculitis on biopsy. You've got a systemic eosinophilia, although it's not high grade, and sensory neural deafness, which is recognized as an EGPA presentation. And there are a number of reports of that. So I would argue you do surely have to make a working diagnosis of a form of eosinophilic vasculitis. Vasculitides don't read medical textbooks, so in case this, it can be to try to prove that it's one classified vasculitis or another. But you've got a vasculitis histologically, you've got a systemic eosinophilia. It seems unlikely the sensory neural deafness developed acutely by sheer chance, and it is well recognized as a vasculitis presentation. So you surely have to manage as a vasculitis. Whether you call it a confident working diagnosis or a tentative working diagnosis, the most damage will be done if you don't manage accordingly.
Yeah, he has significant weight loss. If we look at him, he looked emaciated kind of. So, and they were worried that it is it a malignancy or something? So that is why we did all this workup. And let us see how is so Sandeep, if there is a ANCA and PR3 negative, you can still go by biopsy report, right?
Yes, 30% of EGPA is ANCA negative most of the time.
He has history of asthma, yeah.
But the other thing I would just consider is, could this be also the first presentation of a relapsing polychondritis? Because that also can explain the hearing loss, and it can have a secondary vasculitis. It is a close differential for EGPA.
Will it cause eosinophilia?
Yeah,
it has been described.
Okay.
I mean, from a management perspective, it doesn't change much. It is still steroids and immunosuppression.
Okay.
In some of the series, the lung function profile suggests that a vasculitis and relapsing polychondritis may be more than 50% likely, but not always fair enough for you to start by diagnosing it. So that's an interesting idea.
Is there any biopsy, like you do PINA biopsy or something, Sandeep, for proving that?
Is that
Actually, madam, this biopsy is from the bronchus. No?
Yep.
So then if you, I mean, I just thought of it because you have cartilage inflammation, you have lung parenchymal inflammation, and there's hearing loss, which is well described, and eosinophilia.
So you feel this is sufficient for starting treatment for vasculitis, right?
Actually, ideally, you need 2 areas of cartilage inflammation as per, I mean, if you just look at all the criteria. I mean, the year, I guess we'll have to count it. But like sir was saying, I mean, if you don't treat, then the damage is often irreversible, and it might be, and he's responding because his pneumonia has improved. I mean, this would be someone that from our side, we would definitely consider a second line, because even if it's EGPA or this, he is good candidate for rituximab for both.
Sure. They are willing to start treatment, actually. They don't mind if we give any diagnosis and all. And Ritu madam, you are sure that, because my pathologist might sign off this as a eosinophilic inflammation of some kind. They may not report it as vasculitis. To be honest, they have not yet reported, and they may not eventually report it as vasculitis. But you feel there was a vascular inflammation and eosinophilic inflammation of blood vessel, right?
Yes, ma'am. And also there's an ill-defined granuloma also, I feel, is coming up somewhere. And I would like to polarize it and see.
Sure.
Only I was just worried, you mentioned exposure to pesticides. Could that be drug-induced exacerbation or something?
It is in his mind. They go in Munnar, and then they don't have anything, but because Munnar is a site where cardamom plantations are there and people put pesticides, so he used to think like that, but wife does not totally agree. But he used to think that whenever he goes to Munnar, the problem increases, where the weather is also cold.
Okay. Nice case. Yeah.
Thank you.
What
I managed to
about?
get the, sorry,
Yes.
I managed to get the old CT in case you want to see it. Sorry,
Was it organizing pneumonia? We can just
yeah, I can just share it once quickly.
Because it was labeled as organizing pneumonia, and I felt it was not any different than what I'm seeing right now.
Yeah, exactly. It's the same only. This is 3rd of May 2024. It looks quite similar. There is nothing really foreign. There's no consolidation, or there's no.
Yeah, it was very difficult for me to like, because I just blurted it out in front of them that there was nothing to suggest. So they were like, was I given steroids just like that? Anyway, it's okay.
Yeah, nothing different.
Nothing different, right? Yeah, that's it. Okay, we'll move on to the next anything. I think this we will take it as vasculitis and rheumatologist reference. Yeah. We'll move on to case 4, which is Mr. S. This is going to be only Aparna's case. Anyway, Marin, you can present. Yeah.
Yes, ma'am. This is a 73-year-old gentleman. He's from Kollam. He's a known case of diabetes, hypertension, dyslipidemia, CAD, and transitional cell carcinoma. He does not have any respiratory complaints, no significant family or exposure history. He came to us for fitness for surgery for TURBT as he was diagnosed with high-grade bladder cancer. His vitals were all stable. Respiratory auscultation was normal. His blood workup was also normal.
Yeah, just this is just an interesting case which we found out on a just incidental finding. Over to you, Aparna. There are 2 CT scans. Yeah.
So there are 2 CTs. One is from April 2024. Other one is January 2025. So because it's part of the CT abdomen, we don't have HRCT sections, but what we can see is some very minimal subpleural, some bands and little bit of ground glass and minimal reticulations in both lung bases. the rest of the lungs actually, like almost from carina is covered, and they're all looking quite normal. Just this very extreme lung base, very minimal changes. And this is the January 2025. So in this also we do see the similar changes, minimal subpleural like bands and minimal reticulations. But the left lower lobe, whatever we were seeing, it looks little better, in fact, on the January 2025 CT. But here maybe there's slightly more, but rest of it looks like is looking slightly better. So, I mean, the question I'm understanding is whether this
Is
qualifies
interstitial lung,
as
yeah,
ILA,
yeah.
yeah, interstitial lung abnormality. So I think, I mean, they say at least 5% of a lung zone, which I don't think it is really 5% of this zone, very, very minimal involvement. Plus, between this April to January, that is some 6 to 8 months, there's not much change. Maybe if at all we can do a HRCT with some prone also to see how much of
Yeah.
this is actual really changes, and then we can decide.
Yeah. So 5% will be how much, by the way?
Yeah, I know. I mean, not
Well,
really
how many lobes
calculating.
you want?
No, 5% of a zone. Like suppose we take this whole thing as a
Okay.
lower zone. Is it really 5% of that whole
Oh,
volume of this zone?
and that will
Yeah.
be quite too much, no? Okay.
Yeah.
Okay, no problem. Yeah, I think that was it. Yeah, I'll just share the final questions, if any. I'll jump all other things. So, do we chase it as early ILD or observe with risk stratified surveillance? Do you think I don't know whether patient will come back to me or not, but I found that was interesting, so I just presented. But if we really see 5%, how frequently you do CT scan?
I think there's no definite specific guidelines, but they say if it is like the lower lobe and with some fibrotic changes, subpleural and fibrotic changes, those have a higher chance of progressing. So we should monitor them more closely.
Okay.
Whereas if it is non-fibrotic, maybe we don't have to monitor so often.
Would you call this a non-fibrotic or a fibrotic ILA, Aparna?
Yeah, I'm not. I think
She's
first
not
of all,
committing for ILA.
yeah.
Yeah.
Just
So,
prone, at least we
sure,
should do
sure.
it. Yeah.
Yeah.
Sure.
I think we'll move on to that. We are
Well, you
just running.
start see any traction bronchiectasis, because if you didn't, it's non-fibrotic. Even if you've got reticulation, it's still officially non-fibrotic.
Yeah.
If there's no traction bronchiectasis.
But in a very large Chinese series, actually, it didn't matter. As long as it was subpleural with reticulation, you have the same risk of progression as in so-called fibrotic ILAs. But that radically increased the group with risk of progression. This threshold, you're saying 4.5% is not a disease, 5.5% disease.
Dr. Patna, do you think this might have... Sorry, was Sumit talking?
No. I think somebody else
There's some
was.
background noise from Sumit's.
Dr. Patna, do you think it would make a difference if you proned this patient and repeated the scan?
Yes, sir. I thought at least prone we should do before really labeling it, whether it's just some dependent or some. Sometimes we are seeing these kind of bans in this post-COVID also. We don't know.
Exactly.
I mean, I don't know whether.
You're
And
going,
the last CT is actually 1 year ago. So if at all,
you're
it's
going to lay down lung function as a baseline. I might have missed it. I didn't hear the lung function. But if you're actually going to monitor this patient, it would be nice to know where the lung function is in the normal range.
This would have been done. Because it was post-operative, pre-operative fitness, but we have not put it in this slide, sir. I'll go through that.
Stuff that, as long as the lung function is stable from here,
Yes, sir.
you have to drag the patient back for further scans. Mind you, you might find it easier to get scans than you do to get lung function. So maybe that's what you'll choose to do. But the issue is, if you find the FVC is, say, 82%, and you haven't done the lung function before, and you don't know what the premorbid lung function was, it's very difficult to interpret that.
Yeah. I'll go through
That's all. I just wanted to go to that again. Traction bronchiectasis would be a sign that this could progress.
No.
No.
Fleischner definition, which I think is still used, of fibrotic requires you to have either honeycombing, in which case I think you might say it's early IPF anyway,
Sure.
or traction bronchiectasis.
Right.
You don't have one of those two things. You don't have a fibrotic ILA, so you can have reticulation.
Oh, okay. Okay.
Chinese series, risk of progression was down to distribution and the presence of reticulation. And you met the Fleischner official definition of a fibrotic ILA, which was in 8% of patients, or whether you were in the 48% that had reticulation subplurally, it was the same risk of progression. So the other thing is this 5% threshold is just so artificial. I get to say something, or else the majority of us at our age, or my age anyway, will have an ILA.
Okay.
So
Moving on to
I thought, would you think that DLCO is a more sensitive marker of progression than FVC?
Well, the trouble is DLCO very often patients are smokers, and what we do know, at least in one of our series, you had to have, I think, by the time you saw emphysema on a scan, your DLCO was down to 70% on average. So if somebody's been a smoker, it's a bit deceptive. This whole game of putting lung function, symptoms, and disease on CT together is rather artificial. So I tend to put more trust in the FVC. But if the DLCO is down at 55%, then I think you've got to get worried that the CT is underrepresenting ILD, which could easily be the case. So I think it's tricky. You end up saying that if the lung function's normal, then you're happy. If the lung function is unequivocally abnormal, you strongly suspect the CT might be underrepresenting what's there. And if you're in between, you set your monitoring according to how in between you are. So I don't, there's a rigid formula here. And then and you find you're setting your monitoring in part from the anxiety of the patient or family as well.
Yeah, moving on to fifth case. Marin, we can quickly go through the history and CT.
This is a 38-year-old gentleman from Kerala. He is employed in Merchant Navy. He's a known case of asthma who presented to us with shortness of breath, wheezing, chest discomfort, and cough for around 1 month. He was admitted elsewhere for the same and treated as community-acquired pneumonia. He has exposure to pigeons and a history of lung cancer in the family. His father passed away because of lung cancer. His vitals were normal. Respiratory auscultation is also normal. His total WBC count was increased, 14,300, neutrophil predominant, and ANA was negative, ESR was 7, CRP 0.78. ANA profile was borderline positive for nucleosomes. We did an extended HP panel for him, which was negative. His pulmonary function tests were normal. DLCO was reduced, 62%, KCO was 60%. 6-minute walk test, there was no significant desaturation.
Yeah,
No
Aparna.
So this is a HRCT from 4th of December. I don't have any other previous one when that community-acquired pneumonia was there. In the left lower lobe, there's one tiny high-density, probably calcified nodule. Other than that, the lungs are looking quite normal. Maybe there's some mild bronchial wall thickening. I don't really see anything else in the lungs. There is an expiratory scan, which also doesn't show any significant air trapping. Looks to be within normal, whatever little bit of inhomogeneity we are seeing. There's no significant nodes also. Pulmonary artery is normal, nothing really significant.
I think the previous CT scan was also identical, and our radiologist also reported this as a air trapping and small airway obstruction. I believe that is what the report was.
Yeah.
But because he's planning to go back, he was very much concerned that whenever he comes to his home, that is the time. So their duty is like 100 days at job and 100 days at home. So whenever those 100 days which he spends at his home, he's exposed to pigeons, and they did all the things which is possible to prevent it. But still, the symptoms are more at home. So we did bronchoscopy and lavage, and that was not showing any significant problem. I didn't do biopsy in this visit, and we found 82% lymphocyte. Alveolar macrophage of 82 and lymphocyte of 6% with neutrophil of 12%. No other abnormality or anything positive. So the questions to the panel is it HP pattern or not? And if I do think that this is HP, should we treat the patient, because he's saying that when he's going there, he doesn't have any symptoms. So in such patients, do we really need to treat them when they are going? Like he's planning to go back in January somewhere. So I didn't start him on. I just gave him a small dose of steroids for his current problem, but I'm not planning, and I didn't do biopsy. So should I do biopsy? That is the questions. Yeah.
I don't know what you will biopsy, Asmita, and I don't think I would treat it's not making any sense. So you have normal lung function. What would you want to treat, Asmita?
So he is very symptomatic on a minimal exertion. That's what he's saying, and dry cough, which was his main complaint. So before he goes back, he wants to become his best baseline. So he was worried that what will happen if he goes there, and then the pattern is just keep on coming back and going back, like the same CT scan, which was inspiratory expiratory changes are same. Previous CT was also like that, and every time when he comes to his home, this thing happens, otherwise it does not happen. So I would definitely be happy giving him inhaled steroids considering his asthma background, but anything else needs to be done.
I think that should be enough, and look for
Yeah.
the non-pulmonary causes of his breathlessness. I
Yeah.
think you'll have to, his echo is normal, right?
I don't think I did echo.
Probably did.
Yes.
Given the fact that he's going to be at sea, I think ruling out a cardiac issue is also important.
Okay, sir.
He has a KCO of 60%.
Yes, sir.
KCO is the most reproducible lung function test of all. It's more reproducible than FVC. It's incredibly tight, and that is unequivocally abnormal. So a KCO of 62%. He on BAL was, if it was at a good return, he had a neutrophil count of 12%, which
Yes,
is 4% that is normal. So there is something going on, and that something in some way is giving you a vasculopathic profile. But the way that can happen sometimes is with really subtle infiltration. You're not dropping your volumes, but you do drop measures of gas transfer. So you think it's vasculitic, but it isn't. So it's a bit confusing to know what's going on. I think my worry about speculations on HP is that I really would have expected a lymphocytosis if you had extensive subtle infiltration you weren't seeing on CT. But you have a sense that there is something going on with that KCO and that BAL neutrophilia. Now, if he had a community-acquired pneumonia shortly before those lung function tests were done, then I'd say don't interpret them yet, just come back and repeat the lung function. If he could have had an infection that he thought was a bit subclinical, I'd still be saying it's odd enough that you don't really want to do anything radical till you've confirmed with repeat lung function that that is where the KCO is. But I don't think you can write it off. And when he's got ongoing symptoms plus that KCO, you might be driven to some sort of biopsy procedure if that persists, if his symptoms persist. I think there would be a role of establishing what's going on, but obviously you can't promise you will get an answer from a biopsy, but it is difficult.
So
I
I
mean,
was thinking of when he comes back, like presently he's planning to go for 100 days or maybe even more than that. And when he comes back, my plan was to repeat a CT scan. And then if it is still showing a pattern of kind of like small airway or HP, I might do biopsy this time. Next time I will do bronchoscopy and biopsy. If the symptoms are persistent, if there is a progression or if there is no improvement.
I think the other thing about HP, we always key straight into the lung manifestations of HP triggers. I'm sure you're the same. I've certainly seen a handful of patients who get nothing but systemic features. And with exposure to birds, they do get this very compelling systemic autoimmune type picture. So you might just wonder if something is happening in vessels to do with that. Since you very nice exposure link, it's very difficult to ignore that.
Okay.
So
Never thought about it.
may I suggest you do his lung functions as soon as he returns from his voyage and
Yes,
do
sir.
it before he goes? Let's see what's the difference between the two.
Yes,
Brilliant.
sir.
Does iOS helps in differentiating non-fibrotic HP with as against a small airway disease? Because I guess in some of the small airway disease where we see a lot of mosaicism, we do tend to see some drop in the DLCO as well. That's what I've seen. So is iOS a modality that can differentiate between the two?
Mm.
Question.
I don't use it too often, Sumit, so I wouldn't be able to comment. Pralad, do you use it,
I,
iOS?
I think we use it for differentiating small. Currently, what we have actually seeing that if you have inspiratory and expiratory methodology of finding out on X values, then probably it do differentiate ILD from
Yeah, theoretically,
no, but
but
it
we do
didn't match
not
the
have a
data.
data. We do not
Yeah,
have
we don't
data.
have data.
Yeah.
We have to
So
look for it
I,
actually.
I believe that if we can't differentiate by HRCT and other things, iOS to
So,
differentiate between this and that will be slightly overstretched. Yeah. Move on to the last case. We are already very late compared to other days. Marin, quickly. Yeah. Case
Uh,
6.
this is a 57-year-old male who's from Kerala. He's a food outlet owner and a known case of chronic liver disease who presented to us with dyspnea on exertion for 2 years, which worsened over the last 10 days, which was associated with cough with expectoration. There's no history of smoking, no significant exposure or family history. When he presented to us, he required 5 liters of oxygen to maintain saturation. He was hemodynamically stable. There was grade 3 clubbing and bilateral diffuse crepitations on auscultation. His blood workup, TBDB was elevated 3.16 and 1.98. OTPT was 56 and 22. Serum creat was 1.18. Ammonia was 55. ESR was 11. CK was 145. We did a blood culture, urine culture, serum galactomannan, everything was negative. His IG immunoglobulins, IgA was elevated, 766, 400 is the cutoff. IgG, M and E were IgG and M were normal. IgE was elevated again more than 2,500. Serum ACE was high, 120. RA factor was positive. Anti-CCP was negative. His ANA profile was negative. Myositis was negative as well.
He could not do. We discharged him on when he was on 5 liters of 4 liters of oxygen, but we could not do his this thing. But contrast echo was done. Yeah.
Which showed contrast in LALB at the end of 5 cycles, 5 cardiac cycles.
Yeah. So there was a suspicion that are we dealing with hepatopulmonary syndrome, and is the hypoxia secondary to only because of fistula, or there is some interstitial lung disease going on? So there was a CT scan which Aparna will stand. Yeah.
The CT is from 16th of December, and we are seeing multiple focal areas of ground glass opacities in both lungs, both in the peribronchovascular as well as peripherally, involving upper, middle, and lower lobes. And in the right lower lobe, it's become denser, and there are focal areas of consolidation also. There isn't any significant fibrosis in the background, but we're just seeing all this extensive ground glass. Some areas, there is some intra and interlobular septal thickening, which is giving like crazy paving like appearance also. So this is the main findings in the lungs. In the mediastinal window, there are some small nodes. Some of them are showing some faint calcifications also. And none of them are really significant, maybe like 8-9 millimeters the nodes are. Pulmonary artery is not dilated, and he has obvious features of chronic liver disease. There is extensive abdominal varices, collaterals are there. So so the lung findings, the things that we can think of is, one is whether it is like infection because he has recently worsened. Organizing pneumonia would be the other. Hemorrhage may be another thing to consider. Hepatopulmonary syndrome per se, what we see on CT may be more like whether we can see small shunts, or like we may see prominent vessels going up to the periphery, or like some small AV fistulas. So I am not really able to see any small any definite AV fistulas on the CT, but we may not see it also. We may only see that in the contrast echo. But these things are not, I mean, we will have to evaluate what these are,
We have to
right?
do repeat CT
Yeah.
scan. Yeah, you're right. Even my impression was it a viral infection? But the X-ray did not show. Actually, he was admitted outside, and in spite of he improving or his oxygen requirement coming down, the X-ray did not show any improvement at all. And we discharged him on oxygen. So I think my questions were, just a second if I can share. Yeah. So was it like viral pneumonitis on CLD versus early rapidly progressive ILD? That was the doubt, but a myositis came negative. And uh, is there acute reversible process or evolving fibrotic disease? And presently, I just gave him a short course of steroids, which is like recommended even if it was like COVID related pneumonia or anything. But uh, if I do a repeat CT scan and it does not go how aggressive, because we have got CLD which is proven, so how will I go proceed? So if anything other than like repeat CT scan,
What's his
anybody wants to
INR?
say?
What's his INR?
INR was 1.4 at the time of admission, which was status quo. He developed one episode of severe hypotension, which was reported earlier also, and I believe it is a sympathetic, some parasympathetic sympathetic imbalance which happens in CLD. We could not find any reason. His BP map went below 40, 45, some amount of time requiring noradrenaline and all, but nothing, no bleeding as such. So I don't know what's the, like, he has very severe CLD, and we might think of transplant for him provided this thing gets cleared, liver transplant. So
But his rheumatoid factor is strongly positive,
yes, sir.
Asmita,
Yes,
and
sir.
his asthma is negative. So there's no autoimmune hepatitis.
Yeah, it doesn't look like he has. He was working as he was running some government on bar shop or something like that, and he was alcohol related chronic liver disease. That is proven, like because
Was
of
alcohol.
ASTL. Yeah, ASTLT ratio also matches with that. So alcohol related CLD.
So, okay. I was just seeing that strongly positive rheumatoid factor and wondering whether this was all HPS in the lung. But we have seen some unusual patterns in hepatopulmonary syndrome, Asmita, which include these patchy ground glass opacities. And I
Okay,
know you've given him steroids, but
no
very,
improvement.
very hard. Yeah. And what is your hepatologist saying about his liver?
So they counseled him about transplant and all, but during admission, either it is alcohol withdrawal or because of delirium, he was becoming very violent, and we have to discharge him very fast because every night those symptoms were arising. So I have sent him home, and I might follow up him in OPD after 1 month. And if there is a definite improvement on X-ray, then only I will consider CT scan. That's what I was thinking right now. We discharged him on oxygen, at home oxygen with other medicines. And transplant people are considering. for transplant, considering hepatopulmonary syndrome itself is an indication. Yeah.
So, yeah, so he's already far out on the liver disease to be considered for transplant. Aparna, can you see such patterns in hepatopulmonary syndrome?
That's what I have not really seen this much of ground glass. I have seen small shunts or sometimes just like vessels going up to periphery and such things, but not this much of
Do you see a lot
vessels.
of HPS at CMC?
We do see now and then, but the contrast echo is one thing, but he has got so many other collateral. So any photosystemic shunts can also cause this contrast echo to be positive, I think, because he may be having like splenorenal shunts and all those things. Whether that can also be causing, I'm not very sure whether that itself could be
Yeah, so then
causing.
I think probably after Asmita, you give him steroids since you've started him on that 6 weeks.
Yes, sir.
Probably repeat a scan. Any
The
particular,
scan.
yeah. Yeah, Prala?
Yeah, repeat a scan and see.
Yes, sir.
And I think that you can sometimes take help of your nuclear medicine department for the shunts also.
Did the
So,
patient receive any albumin?
no, we didn't give him any albumin, not yet. He was with me only for 5 days, 6 days. I discharged him
Sometimes
very
they give
fast.
it for hepatorenal or, and at times we see that after the albumin, you get this multiple ground glassy shadows, which is a part of edema and it takes its own sweet time. It doesn't behave similarly to a standard cardiogenic pulmonary edema. It takes a lot of time for these shadows to disappear. It is very unusual. I know it is just ground
Yeah.
glassy. There are no effusion, something, but that at times happens in CLD patients who are given albumin.
So what the patient is saying is he was perfectly all right for 1 month before. What the family members are saying is the problem started after COVID. So since 2022, they are saying 2022 he developed COVID, and since 2022 this problem is going on. They are seeing him more and more breathless. However, the patient is denying. But he agrees that for last 1 month I am very sick and I can't take on like carry on with my any daily activity. So something which was going on has been worsened very acutely. That is what I felt, and I also agree with Aparna's this viral pneumonia, because I also felt that this can be very well a viral pneumonitis or something which might resolve. But unfortunately, this was outside CT. We didn't repeat CT because I am planning to repeat CT scan after 6 weeks. Yeah.
All those other symptoms, Dr. Asmita, like they say some orthodeoxia and such
So he didn't
placophlia and
have,
all.
we checked for it. He didn't have those symptoms. But his clubbing and all those things are telltale. Like this hepatopulmonary syndrome is very common in Kerala, Rajan sir. If you were asking her, this is like Kerala is we see CLD right and left.
So you have very good liver transplant centers also
Yeah. In
in
Amrita
Kerala.
we
Yeah,
do
that's what
also.
I was asking, if
Yeah.
Aparna's not seeing it as commonly as you at all, your center on chronic liver disease?
Um, I'm slightly at a loss in this case. I don't believe those CT appearances are likely to be hepatopulmonary syndrome, but just to be sure, I looked online just now to see if they were described, and they do not seem to be. I do think this is likely to be one of those complex situations where several things come together. So I'm interested in immune dysregulation following COVID in a vulnerable patient. I don't believe there'll be rheumatoid driving the liver disease because anti-CCP is negative. I do wonder if there's something going on boosting antibodies. The serum ACE, you've got to discount in chronic liver disease. You get elevated serum ACE. You don't have to summon sarcoid up here. But
Okay.
I suppose if I was saying, how could this be messed up? How it could be messed up is there's an immune dysregulation driving what you see in the lungs and you don't treat it. And so rather than coming up with a diagnosis here, I think the key question is, can you afford not to treat as for immune dysregulation? You can't turn that scan very compellingly into hepatopulmonary syndrome, I don't believe. This started following COVID. And so whatever this is, and you can't label it, The real question is how can you most damage the patient by your management choice? And I think the danger here might be failure to treat for immune dysregulation. But look, that's something we probably should all vote on, because I'm not sure I'm going to be any better than anyone else in reaching a conclusion. I'm worried about how you mess this up.
Yeah, well, I think we don't need to vote on it because Asmita started steroids, right?
Yeah. Yeah. We already gave him 125 during admission and has been discharged on 30 milligram prednisolone, which I will taper in 1 month. Yeah.
But that's the question, though. If you're managing with conviction, it's how you manage in the longer term. And that you probably have to commit to some sort of longer term regimen.
No, in COVID, we don't give it for long term, right, sir? We give only for a short term, and if there is improvement, we can just discontinue, because that is what will be interesting to see if the CT scan is showing improvement or not.
So all I'm saying with the COVID, this is not post-COVID as we know it. This is downstream. You get into this whole variety of phenotypes where there is immune dysregulation. Now, they get swamped by the sheer number of people with acute COVID. And we went through this complete mess where long COVID was said to be symptoms lasting 6 months. And we were focused on bad disease in ICUs. And you were mixing together patients that were post-acute COVID and those patients that were in the process of developing an immune dysregulation, much less frequent overall, but because COVID was so common, you ended up seeing a lot of them, but with a bewildering array of phenotypes. So I wouldn't be using a post-COVID rule for this.
Okay.
I'm saying you've got what may well be a weird form of immune dysregulation, and you're actually handling it because it's 3 years later that this is progressing. And I wouldn't use post-COVID rules for that. Say that may have been a cofactor in bringing something out.
Yeah, that's it. We
So we
had.
don't really know it's progressing, isn't it, Professor Ithal?
We don't have any previous imaging, not even X-ray, because I was also wondering, because presently we have X-rays and everything, and even on X-ray I can make out that there is no improvement, so no point of repeating CT, but it will be interesting if it resolves.
And becomes critical to repeat the CT if they're planning to take him up for a transplant.
It is, yeah. That I have explained to the relatives that if this is interstitial lung disease, no point of going for aggressive treatment for liver, because the chances of infection to the lungs will affect mortality, survival rather than mortality. Yeah. Okay.
So, in this context, we had a few patients who had concomitant ILD and who were end-stage liver disease. The question the hepatologist put up is, what is the prognosis from the lung point of view for us to stop from doing a liver transplant? Because for those patients, the life expectancy is 6 months. So they would say that if you can prognosticate that this patient is going to live for at least 2 years, to the best of your knowledge, that is, and with whatever extra risk involved in doing the surgery, then they should still have the surgery.
That's good, yeah. That makes sense. If patient is not going to survive for more than 6 months by liver problem, and lung problem doesn't look that bad, but yeah.
Yeah, but you're seeing what you can reverse now, Asmita, and if you're able to reverse something, the prognosis is obviously better from the lung point of view.
Yes, sir.
Probably quite a bit of what you see on the scan is not fibrosis.
Yeah.
This rule about ILD in the liver probably gets biased towards IPF fibrotic ILD. So the term ILD is not necessarily very helpful. And the moment you've got a response to this, I think you could probably argue that the lung disease won't kill this patient in the next 2 years.
Agreed, if they want to go ahead. So it's almost 6:40 and we are going to stop now. And thank you so much for being with us for so long, Aparna and Mohan sir, Atul Well sir, and Thank you so much, Sumit. Your inputs were very much appreciated, Prabhu Desai sir.
Thank you. It was a pleasure.
Yeah.
Rather people spent a Boxing Day morning, actually.
Yeah, we did a good job. Yeah. And the next meeting will be on
So the end of last night.
January, in the new year. Yeah, we'll see you in 2026. Yeah,
Ninth.
9th of January 2026. Thank you so much.
Thank you.
Okay.